Good afternoon, everybody. Welcome. I'm Janet Gatlin with Rogers Behavioral Health. Joining me today is Dr. Matt Boyer, an addiction psychiatrist at our Philadelphia location, and Dr. Lauren Scaletta, our clinical psychologist at the Harrington Center for Mental Health and Addiction Recovery, for today's webinar on harm reduction. Before we get started, I would like to give our participants a quick overview of the format. The webinar is scheduled today for 90 minutes. To receive CE credits, you must be logged into the webinar for the entire program. There's no need to check in. Your attendance is tracked via Zoom or login records. A PDF of the PowerPoint slides and a list of references will be available immediately after today's program via email with your link and the personal dashboard on cego.com. In addition, a recording of the webinar will be published on a resources section of our website for you to be able to join or look at and rewatch within a few days at rogersbh.org. Today, our presentation will be approximately 70 to 75 minutes. Following the presentation, I will facilitate a Q&A session. You will note that the deactivate chat feature, I have deactivated the chat feature, as we have found that can be distracting at times for the presenters and the participants. If you would like to ask a question for today's session, please use the Q&A button to send a message. That is at the bottom of your screen, and you can simply click on the Q&A button on the taskbar at the very bottom. I will review all the questions submitted, and then the presenters will be able to address them during our webinar today during the Q&A portion. Finally, we have enabled the closed captioning for this program. At the bottom of your screen, there is a live transcription button. From that, the menu, you can click Show Subtitles to view any audio as text. If you would like to enable the subtitles, simply click Hide Subtitles from the live transcription menu. Now, with that, I'm going to go ahead and turn it over to our presenters.
Thank you, Janet. So as Janet described, my name is Lauren Scaletta. I am a clinical psychologist working in the residential level of care in a dual diagnosis or co-occurring mental health and addiction recovery focused program. So a little bit before we start our presentation, well, first I got myself off mute, so we're off to a really good start. But my colleague Matt and I would like to share with you some of the basic foundation of harm reduction, looking particularly at how is harm reduction used, what are some examples of it being used in the community, what are some of the benefits, especially in reaching some underserved communities, and I'll speak more on that, and also some of the challenges facing harm reduction when we consider all of the factors that it takes to implement some of these strategies. We will go through our webinar and split some of our content time. So we will begin with a discussion of some of the barriers to the other very common treatment approach, being abstinence-only treatment, and then also discuss the basic definition of harm reduction, examples of what that encompasses, overviewing the evidence base for that, and then also a brief but important overview of what are some of the highlights of current policies that exist out in the United States and across different states right now. What are some changes that have recently happened, because things are rapidly changing all the time, particularly in the last couple of years. And then also any issues raised by harm reduction. We will end with some case discussions and we'll contribute how we could interact with some of the harm reduction strategies we used for some of the cases that we put together. All right, so I will kick us off. What we saw in around the 1980s was a time of heightened fear for the AIDS or HIV epidemic. So at that time, we saw harm reduction methods for substance users took a spot in the international spotlight, with a lot of discussion in it in the UK, in the United States, and being able to find out strategies to how to address how HIV was impacting the substance use population. Programs in some areas were offered by giving outreach workers, by educating, distributing education, and sterilizing equipment for drug users. So this allowed some areas to be hit in a less severe way by the HIV virus. In that was the first model of harm reduction that existed. And the core idea of that harm reduction model is to reduce those public health risks that come as either a primary or secondary risk to substance use. For example, overdose deaths would be a primary target of reduction or of the harm reduction, while other targets exist, such as the reduced spread of HIV, lowering the number of long-term health conditions that would often result from chronic and heavy substance use. So the goal of this is to improve the life and ability to recover for folks who are using substances, and also improve public health overall. Harm reduction, unfortunately, like other programs that are surrounded in controversy for supporting reduction instead of the other option of immediate and total abstinence, can often draw criticism due to the fact that to the untrained eye, it can look like condoning substance use and abuse. I instead like to look at it as a way to make progress towards long-term healing and abstinence in a way that's more realistic to the reality of the brain disease of addiction and the fact that for humans in general, change is difficult, no matter what the change is. So while it may be unreasonable for us to expect a total 180-degree change of the people, places, things, social situation, other factors for the populations that we serve for them to enter recovery, the harm reduction model can also offer a middle path. It can assist with the mitigation of those risks. And it is reaching populations that have not been typically served by healthcare and mental health care in the past, particularly those who are in rural areas, those in the BIPOC community, and low socioeconomic populations. I once heard a former patient state this particular view on harm reduction. They said harm reduction is abstinence and abstinence is harm reduction. While it may not be a widely known or, we can probably pick apart what that actually means. I liked that in the sense that the ultimate goal is healing for the brain without substances, but we have to start somewhere in the reduction of use. And we also are tasked with reaching populations where we know substance use disorder prevalence is high, but we are not finding those folks presenting for treatment in traditional residential, sober living, or other settings. I practice here in the Milwaukee area, and that is something that we see anecdotally all of the time in our clinics. And knowing that there is a community who is very strongly being impacted by overdose rates that are continuing to climb, but also knowing that in my daily work, a large portion of the population are white folks seeking our residential services. So the hope is with more harm reduction resources, we can be able to expand that scope of practice. In the next few slides, I will review some of the barriers to traditional or abstinence-based treatments that can be addressed by harm reduction. And we'll also discuss a short overview of the why of this treatment approach. While we cannot fully cover the full depth of this topic for this limited time we have together, Matt and I hope to serve a new foundation for a topic where you may be unfamiliar with it, or as a way to review some of the considerations for those of you who have been already utilizing harm reduction strategies. I think it's important, first and foremost, to know why we are using this particular treatment modality. And it is largely based in the fact that there are all of these barriers to seeking treatment. whether it's personal barriers, cultural barriers, or systemic financial barriers. We recognize that treatment access often exists in larger metropolitan areas, but the circumstances have to be right. We have to be close to those treatment facilities. We have to have transportation. There has to be insurance that covers those. So often the general access is really difficult to be able to access some of those opportunities to be in recovery. I think it's also important to recognize individual motivation for change. We look at the stages of change model, and we recognize that people move throughout the stages of change, not within a linear progression, and often can bounce back and forth between different stages at a time. If someone is not motivated for a complete change, at least we can start to build upon existing motivation with harm reduction when motivation for change or total abstinence is a current barrier for an individual. We also can look at craving management. For some folks who are trying to go the abstinence-only route, there may be a significant number of cravings that occur that can derail or start to become the forefront of their mind instead of being able to think about the long term. That makes sense. There's a very strong physiological phenomenon going on with cravings. And we know that, for example, if you've ever been injured or had a very bad day or are very stressed out, sometimes we can get tunnel vision into what will make me feel better rather than let me think about my long-term goals. I acknowledged insurance coverage. I think it's something that as providers and clinicians, we are all very aware of, particularly for me. I can speak at the residential level of care. Insurances may flat out say we don't cover residential or we don't cover more than a certain amount of services. But with progression in recovery being nonlinear and being individualized, one size does not fit all when sometimes the systems are set up to be one size fits all. There is a shortage of providers as well. We know that the healthcare field is always facing this with the rising amount of folks who are struggling with substance use, particularly through this time of the pandemic, and also folks who are leaving the field and or it is very expensive to become a healthcare provider. And along with that, there are communities where there may be mistrust of providers. I was looking into some of the research and that we're looking at a variety of populations and who seeks access to treatment, because it's not necessarily that prevalence isn't there across the board for communities, but who is actually showing up to treatment and trusting providers. And in some of the research, I found that non-Hispanic white participants as compared to non-Hispanic Black participants and Hispanic participants, there was a 73 for non-Hispanic Black participants and 49% for Hispanic participants, more likelihood to report mistrust in healthcare professionals, respectively. So we are seeing that there's still this barrier of being able to build the healthcare system to be an inclusive space and to make sure that we're reaching populations that need these services. And that takes time to build that. Financial needs. We know that with addiction, often other areas of life become something that there may be less finances available. Employment may be lost, which is another one I have up here. So at that time, that also impacts that insurance coverage, right? There are many patients that we have here who will lose their employment while they are in treatment and then are finding a way to still access the treatment that they would very much like and have the motivation for. But how do they do that if they don't have the financial means to do so? And when they have an opportunity to be employed again, it is often important to prioritize that employment over, unfortunately, spending time in treatment services, because that is the reality of their situation at that time. In addition to some of the other factors I've included, I think it's important to look at the stigma and shame when relapse occurs. I think in traditional treatment, we have seen that there are folks who, if you relapse while in treatment, there's either a 3-strike rule or a 1 and you are asked to leave, or if you relapsed or were administratively discharged from a program, you might not be able to return to that program for a blanket 6-month period, a blanket 1-year period. We want to make sure that we have strategies in place for if folks are not able to access that treatment because of some of those more based in punitive measures exist. Can we find a way for them to still engage in recovery and start to make those positive changes? In addition, there are privacy concerns that folks have about accessing treatment, feeling like it's difficult through admission processes, or feeling like they don't have the social support to enter a traditional treatment setting. On the topic of barriers and some of the precedent for harm reduction, I would like to point out some of the outcomes that occurred in the turn of the millennium in the year 2000, when Portugal did a blanket decriminalization of their public and private use, acquisition, and possession of all drugs. They decided to focus on a public health model rather than a public order or punishment model. And this was in service to reduce all of these barriers that I've been talking about. Initially, we saw a reduction in substance use, a higher prevalence of folks who sought services, and a focus on human health and human rights in that system. That being said, all of these systems exist together, and where the healthcare field may push forward some of those programs, there's always still room for differing opinion of how to best handle things and the politicization of substance use treatment. So in 2008, Portugal saw pushback, and there was an order in Portugal to create, again, more punitive measures around drug use and possession. So some of these models, like the Portuguese drug policy model, show us that there is positive initial evidence for supporting these models, for removing these barriers. And we can see some of those improvements starting. However, we also see that stigmatization within the political arena, the difference in opinion, and then we're struggling to see a peer example of a society that uses harm reduction models, and that can muddy some of the research and the knowledge we have around it at this time. However, positive steps are always promising. So this begs the question, why harm reduction? It is through the lens of the barriers and what we know from some previous examples of harm reduction that we look at our material today. How do we reduce barriers? How do we use programs that can reach the underserved and often oppressed or highly stigmatized populations that remain unhelped, either by social stigma, systemic racism, sexism, xenophobia, or systemic oppression? We are attempting to access those who are trying to survive while managing a disease that is often falsely attributed to moral failing, rather than an understanding of how a hijacked rewards system pathway, genetics, trauma, and social experience keep folks away from successful recovery without more systems of supportive treatment and accountability. I would like to do one last look at the last point on this slide. Some of the research shows that while there are disparities between who seeks use treatments, some of the disparities between Black and white populations show that when individuals have health insurance and that's controlled for, we do see increased access of those treatment services. So we do know that there is help with reducing that barrier. Today, we will look through some of the basic harm reduction models. So naloxone, overdose prevention centers, syringe service programs, overdose prevention education, education on safer injection practices, medications, particularly for opioid use disorder. And then the first one I will briefly go over is motivational interviewing. I won't spend a lot of time on this because this is pretty widely known for those who are in the substance use treatment realm. From a behavioral intervention standpoint, motivational interviewing was developed for those struggling with substance use disorders, and with the understanding that we move through the stages of change when making meaningful behavioral changes. So instead of pushing a therapist or provider chosen goal of discontinuation of substance use, motivational interviewing is a tool that recognizes autonomy, collaboration, and the evocation of already existing desire to change. So what this means that while it may be difficult to allow a patient or client the space to make a choice, we know that will likely cause harm. We recognize the human right to choose their own path and their choice to engage in recovery all at once or over time. And with that, I will turn it over to Matt to go over some of our other examples of harm reduction.
Okay, thanks, Lauren. And it's great to be here with everyone today. My name is Matt Boyer. I'm an addiction psychiatrist, and I work in Philadelphia. So let's start the discussion on the evidence base for harm reduction with one of the best tools that we have for saving lives. It's naloxone. And naloxone helps to restore breathing. It helps to wake people up after they've overdosed on opiates. You can see the map here. This map is coming from the National Harm Reduction Coalition. It shows all the places that are offering this life-saving medication. And I love seeing, how prevalent it is available, but I'll also point out all the areas where it's not easily accessible. And I think that this map sort of depicts in visual form disparities in access to care that can be tied to geographic location. So I also wanted to mention here that there's a standing order that every state either has a standing order or a mechanism like a standing order to make naloxone available at pharmacies. Next slide, please. Okay, so here, let's look at this study, which shows us evidence from communities where naloxone is helpful. So the authors here wanted to answer the question, what's the impact on the death rate from opioid overdose if we spread opioid overdose education along with access to naloxone? And so the authors answered that question by comparing 19 communities in Massachusetts. And what they did was they compared communities that had access to education and naloxone to communities that didn't have it. So let's move to the next slide. Great. So here you can see the results. And there were 327 rescue attempts using naloxone. Most rescue attempts occurred in private settings. The rescuer and the person who overdosed were usually friends. And I think this is a really important finding. It can be helpful when we're meeting with patients to remind them of this fact. Now, importantly, naloxone was successful in 98% of the rescue attempts. And for the 2% of rescue attempts where naloxone was not successful, the people who overdosed ended up living. So emergency medical services were able to help them. And I'm including a graphic here from the study that I think is really helpful. You can see in the dotted red line and also in the dotted green line, those were the two intervention arms. And the authors were smart how they did this because they had one which they called the low enrollment arm and then another with the high enrollment arm. And what this shows is that the more you provide naloxone and educate people on how to use it, the lower the death rate goes from opioid overdose. You can see in the solid line there, that's the data that was collected from communities that were not enrolled in this special program. And so the authors of this study conclude that by increasing access to naloxone and education on how to use it, that there can be a decrease in mortality from opioid overdose. All right, next slide, please. All right, so I want to move on next to overdose prevention centers. And, we'll talk a little bit about the evidence for them as a harm reduction strategy. And you might be wondering, so what is an overdose prevention center? Well, they're safe places where people who are using drugs can inject drugs. And it's important to note that it's not a place where you go to obtain drugs. So you've already got drugs in your possession and you're going to one of these centers to use them in a safe way. There are not drug dealers selling products at these centers. All right. And in the literature, you'll see these sites referred to in a couple different ways. You'll see overdose prevention sites, supervised injection sites. In Europe, you'll see that they're referred to as drug consumption rooms. Regardless of what they're called, the concept is the same. And overdose prevention centers provide access to clean supplies. And they also offer linkage to social services along with medical and addiction treatment. Now, I'm aware of 2 in the US at this time. They're both located in New York City. And let's move to the next slide, please. All right. So the study we're going to look at here is from the Lancet in 2011. And the authors here wanted to ask a very simple question: whether the opening of an overdose prevention center in Vancouver would be associated with a reduction in overdose mortality. And the authors answered this question by comparing overdose mortality rates before and after the opening of the center. And so what they did was they established a 500-meter radius, and they said anyone within that 500-meter radius of the overdose prevention center counts as having relative easy access to the center, versus the rest of the city, anyone outside that 500-meter radius would have harder access to the center. And what they did was they compared people who had easy access to the center versus those who didn't have easy access. And what they found was that there was a 35% reduction among people within that 500-meter radius of overdose fatality versus the rest of the city. Now, I love seeing that the rest of the city also decreased overdose mortality by 9.3%. But importantly, that difference between 35 and 9.3 was found to be statistically significant. And given that important outcome, the authors concluded that overdose prevention centers should be considered where injection drug use is prevalent, and particularly in areas with high densities of overdose. All right, next slide, please. So here we have a bit more information about overdose prevention centers. I wanted to make sure everyone knows there's nothing novel here. They've been around since the 1980s. We just talked about one in Canada. There are many in Europe. There are many in Australia as well. And to give you one example out of Europe, so in Barcelona, it was shown that there was a dramatic drop by 50% in overdose mortality. And then there's an example here from Australia as well, showing that there were 6,000 overdoses altogether and not a single death among them. So looking at harm reduction from a different angle here, Wood and colleagues published a study here showing that people who inject drugs are less likely to share needles if they regularly use overdose prevention centers. And I don't think this should come as a surprise because overdose prevention centers offer access to clean needles. Okay, next slide, please. Okay, so I want us to move on next now to syringe service programs. And in the past, you may remember hearing terms like needle exchanges, but the preferred terminology now in the literature is syringe service programs. And these are programs that provide access to syringes and needles and drug use supplies. And they also provide education to people who inject drugs. Now, I want to make an important distinction here. So overdose prevention centers offer syringe service programs. However, the opposite is not true. So syringe service programs by themselves do not offer safe places to inject drugs. And I think that distinction is important. Syringe service programs also help with safe disposal of sharps and provide access to naloxone. All right, so there's some research here that I want to talk more about. So transmission of bloodborne viruses such as HIV and hepatitis C is reduced with the use of syringe service programs. And here MOUD stands for Medications for Opioid Use Disorder. And we're going to go into the study in a bit more detail from Fernandez and colleagues on the next slide, please. All right, great. So Fernandez and colleagues published an overview looking into the question of effectiveness of syringe service programs to prevent transmission of blood-borne infections. And I wanted to include this study because harm reduction, yes, of course, refers to reducing risk of overdose and reducing risk of death, but it also includes reducing risk of medical comorbidities, such as HIV and hepatitis C. And we know that these are significant causes of morbidity among people who inject drugs. Next slide, please. All right, so Fernandez and colleagues concluded from their overview that syringe service programs are an effective way of reducing risk for HIV and hepatitis C among people who inject drugs. Of course, the most effective way of reducing harm is by abstinence. And I'm thinking, Lauren, of that quote you provided by your patient. But I wanted to highlight here data provided by the CDC showing that users of syringe service programs are more likely to stop using drugs than those who don't use syringe service programs. And that might not seem intuitive at first. However, I think there's a connection between syringe service programs and overdose prevention sites, since these services provide linkage to addiction treatment. And that might help to explain this phenomenon that the CDC is talking about. All right. The other important point here is that when referrals to treatment are tracked from these services, researchers find an uptick in referral to detox treatment. And that might help to explain how these programs are promoting recovery as well. The last point here on the slide is about crime. And you might be wondering, is this maybe outside the scope of our talk here today? But I think that, harm reduction can show improvements in crime, and there can be benefits at the levels of communities. Now, some critics might argue, hey, isn't it great that HIV rates and hepatitis C rates are lower? But I bet that there's an increased rate of crime in the areas where these services are provided. And it turns out that that's actually not true. In fact, the two studies that I've listed here, one is from Baltimore, the other is from New York City, shows that there's no difference in crime rates in areas with and without syringe service programs. And towards the end of the talk, as Lauren mentioned, we're going to talk about some issues and controversies. This theme of crime, we're going to revisit that theme towards the end of the talk. All right, next slide, please. All right, great. So I'd like us next to move on to overdose prevention education. And this is a strategy in harm reduction that is exactly what it sounds like. What information can we share with our patients to promote knowledge that might help to prevent overdoses? The strategies listed here can all be helpful, including not using substances alone, making sure that you're letting someone else know that you're using, who can check in to make sure that you're not going to overdose and die. You want to avoid the mixture of substances. This is especially important with benzodiazepines or with alcohol and opioids, because that combination can increase the risk for overdose. You want patients to sample a small amount of drug first, and you also want to make sure that they know that tolerance can change. I think that this is especially important for people who enjoy a period of recovery and then may resume use. Knowing that their tolerance will be lower is a potentially life-saving information for them. We also want to dispel the myth that large amounts of drug must be used to cause an overdose. This just is not true in the era of fentanyl, where even the smallest amounts can cause people to overdose, unfortunately. Finally, the last point here on the slide about fentanyl test strips, we're going to go into this more detail, but these are another helpful form of harm reduction that we're going to discuss more in the next slide, please. Thank you. All right, so let's take a closer look at fentanyl test strips. So these are a form of harm reduction that help people to identify whether fentanyl is in the substances that they're buying off the street. And the research question that the authors here wanted to know is, do people change their behaviors when they use fentanyl test strips and incorporate the knowledge of the test results into how they use substances? And what they found out is that the answer is yes, they do change their behaviors. And I want to move to the next slide here to go into more detail about how they change their behaviors. All right. So the authors here report in their paper that when people who inject drugs get a positive result on their fentanyl test strip, they had a 5 times the odds rate of reporting changes in drug use behavior compared to when they got a negative fentanyl test strip result. So how exactly did they change their behavior? Well, I've listed here 4 examples that the authors reported. First, using less drug than usual. Second, administering a tester shot. Third, pushing the syringe plunger slower than usual. And then fourth, snorting rather than injecting. And the authors concluded here by stating that fentanyl test strips may represent an additional effective overdose prevention tool when included with other evidence-based strategies to prevent opioid overdose. All right. So let's keep moving. We're now up to safer injection practices education. So to summarize, so far, we've talked about the evidence-based for naloxone. We've talked about overdose prevention centers. We've talked about syringe service programs, and we just covered overdose prevention education, including fentanyl test strips. So here, this is exactly what it sounds like as well. Here, we're talking about sharing knowledge with patients about reducing risks of harm from injecting substances. And ideas worth sharing with patients, I think, include the following, such as rotating injection sites, making sure patients are cleaning their skin prior to injecting, and not reusing syringes or needles, and then also providing referrals to syringe service programs. All right, next slide, thanks. So there's some overlap here between safer injection practices and syringe service programs. And we've already covered, discussion about HIV, and it's worth reiterating here that safer injection practices reduce comorbidity substantially. And so here I wanted to highlight a different study looking at HIV risk and safer injection practices. So actually, I'm not quite ready. Sorry, if you could go back, thanks. All right.
I just got really excited.
Thanks, Lauren. All right. So, as a reminder, earlier we looked at that article from Fernandez and colleagues showing that reduced risk for HIV. And here we see an article by Aspinall and colleagues showing similar findings that safer injection practices, including syringe service programs, are effective in reducing HIV. Now, the other point here on the slide, I wanted to address that critics of this category of harm reduction might argue, hey, you're basically teaching patients how to inject drugs. How do you know this isn't going to make their drug use worse? And the answer to that is that Fisher and colleagues, they actually asked that same question, and they designed a study to answer it. So in the next couple of slides, first, we want to look at that Aspinall study, and then we'll look at the study by Fisher. All right, I'm ready, Lauren. Thank you. All right, so here's the Aspinall paper looking at risk of HIV transmission. And the authors here, carried out a systematic review, and they assessed whether there's an association between safer injection practices and transmission of HIV. Next slide, please. All right, so they found that having access to safer injection practices, including syringe service programs, had a pooled effect size of 0.42, lowering the risk of HIV. And I have a comment here that assigning one group to an intervention, such as safer injection practices, and another group to a non-intervention arm, at this point would actually raise some ethical concerns, knowing how well this harm reduction strategy works. All right, next slide, please. So the authors here concluded the following. NSPs, and so that stands for needle and syringe programs, which is just a variation on the syringe service programs terminology, should be scaled up, especially in areas with high rates of HIV transmission among people who inject drugs, but should be considered as just one component of a comprehensive program of interventions to reduce both injecting risk and other types of HIV risk behavior. And I think what the authors here are acknowledging is that safer injection practices work, but in isolation, they have less value compared to integrating safer injection practices among a whole suite of harm reduction strategies. There can be synergies that form when you incorporate it among other strategies. All right, next slide, please. All right, so here I wanted to get back to the study by Fisher and colleagues that I briefly introduced earlier, and the question about whether safer injection practices could possibly backfire. And some critics might point out, by saying that you're basically providing information to patients about how to inject drugs. So work by Fisher and colleagues here shows that this is a weak argument. We're going to go into the reasons why on the next slide. All right, so what Fisher and colleagues found is that there's no difference in the number of injections between those using safer injection practices through a syringe service program versus those accessing needles through pharmacy sales. And here NEP stands for Needle Exchange Program. We preserve the terminology that was used in the paper. That's why you see a couple of different variations on the terminology. Also, they found no difference in the percentage of positive urine test results. Now, if it were the case that providing education on safer injection practices to people who use drugs were to increase IV drug use, I would expect a work like this, a paper like this, to pick up a signal there, and that just wasn't shown in the data. All right, next slide, please. All right, so I have two more points on safer injection practices that I want to share. If you know of a patient who is not accepting of syringe service programs, or perhaps doesn't have access to syringe service programs, and you know this patient is reusing syringes, maybe sharing syringes, please share this information with them. It's published on the CDC's website. The link is provided here, and it's a guide on how to clean syringes in 9 steps. Of course, this is not the gold standard harm reduction technique. The gold standard harm reduction technique would be to use a sterile syringe, a new syringe every single time you inject. However, I think the CDC is acknowledging that people know that this behavior is happening, and instead of ignoring it, the harm reduction approach would be to say, let's address it, because we might be able to help people maybe save some lives here and prevent comorbidity. All right, next slide, please. All right. The last point I'll make here is about safer injection practices and HIV and pre-exposure prophylaxis. It's also called PrEP, and PrEP is antiretroviral medications that decrease the likelihood of acquiring HIV. If you know of patients who've shared needles in your clinic, and let's say your clinic doesn't offer HIV testing, please do refer people for HIV testing. If they're positive, they'll want to begin antiretroviral therapy right away. There's a treatment component here. Yes, of course, we know people with HIV do better when they're on antiretroviral therapy, but there's also, a community health component here where we know that medication addresses viral loads, which makes it less likely that they're going to spread infection to other people. Now, if a patient tests negative for HIV, and we know that they're using IV drugs and maybe sharing syringes, then they might be a candidate for PrEP. And the study I've cited here shows good evidence that when people who inject drugs and they take an antiretroviral agent prophylactically to prevent getting HIV, they have a reduced risk of getting HIV, and that reduced risk is substantial. All right, next slide, please. All right, so before I hand it back to Dr. Scaletta, I would like to discuss medications for opioid use disorder. Buprenorphine, methadone, extended release, intramuscular naltrexone. We all know these meds, we all love them. They're really important. They have different mechanisms of action, and they provide protective effects for people who are meeting criteria for opioid use disorder. They are standard of care. We also have evidence showing that there's a useful harm reduction component to using these medications. And on the next slide, I want to highlight a study that's hot off the press looking at this protective effect. All right, so just last month, a new study, this study posted here, was published, and I think that it speaks to the harm reduction component that's so helpful with these medications. The authors looked at people assigned to receive buprenorphine, methadone, and naltrexone, and then they looked at outcome data for these people in terms of the number of overdoses that they had. Next slide, please. All right, so the lead author here was Brandt, and Brandt and colleagues found that patients who did not start on their medication, or those who did start but then they stopped, they were at greater risk of experiencing an overdose than those who took their medication. The authors here concluded patients should be educated about the protective effects of medications for opioid use disorder, as well as the danger of stopping these medications because of the life-saving effect that was shown in this study. So with that said, I'm going to hand it back to Lauren to address future directions.
All right. So in our next part, we would like to talk about some of the recent policy changes, some of the tools and resources that are coming up on the market that are starting to be widely used, but also are seeking either FDA approval or insurance coverage or things that make them more accessible for folks. The first one, Matt spoke a bit already about naloxone and it becoming more prevalent and accessible. So in 2018, we found that the law permitted dispensing and administering naloxone without a physician's prescription. And then last month, or a couple of weeks ago, the FDA followed and approved over-the-counter naloxone and being able to allow that without that physician's prescription. While it is still in the stage of determining cost and what that looks like to access it over the counter, it is a very big step for accessibility, for harm reduction. I think other avenues that we have seen in the community for accessing naloxone without that prescription are things such as free naloxone vending machines that are in places where 12-step meetings are taking place, and being able to make these more accessible to the community and bringing them to spaces where people are able to get them. So with a particular rise in fatal overdoses between November of 2020 and October of 21, we saw about 15.9% increase in those fatal overdoses. And that increased the desperation for tools that will help with accidental overdoses and to find a way to survive an overdose. The healthcare system and research does not exist without interconnectedness with policy and laws. So looking at, while we often look through the lens of most appropriate medical or clinical interventions based on the evidence, those may not be supported by the greater system yet. So that's why each step and knowing where we are in the process can be an important part of the work that we do. So some of the following information relates to understanding the current state of access based on the law by state. There's a really helpful resource that I accessed a lot. So the Legislative Analysis and Public Policy Association released a summary of the state laws. So as I'm sure you were all anticipating excitedly for me to just list a bunch of states at you of where things are legal and not, I will spare you all today. But as of last April, we knew that 25 states and the DC area allowed for at least some individuals to utilize fentanyl test strips. And that will vary by state, whether that is someone who is using, whether that is a healthcare professional being able to provide those, or whether that's for specific centers to be able to use. So in 12 of the states where testing equipment is illegal, and I guess I should cover while we have 25 states and DC where we allow some version of utilizing fentanyl test strips, that means we have a good portion of the country that still does not allow that testing equipment to be distributed and used. It is currently looked at in a lot of those states as drug paraphernalia. Whereas if we know the medical distinction, we can make a very good case for it not being paraphernalia. But this goes back to some of that stigmatization of, do people believe that we are condoning substance use with the presence of some of these tools? So in 12 of the states where testing equipment is illegal or considered paraphernalia, the Good Samaritan fatal overdose prevention law may protect people from criminal penalty. That being said, it's usually on a case-by-case examination. And that means there is not a lot of room when making a split-second decision to know all the factors and to know the law and know whether it is legal to use fentanyl testing strips and being able to offer that to someone who may need it. So there is still room to grow in accessibility of this tool. Another one I would like to highlight would be the presence and availability of syringe exchange programs, or as Matt said, syringe service programs. So being as of last year, we have more accessibility for syringe service programs. 39 states and DC allowed for, again, that very vague terminology of at least some individuals to possess and use needles and syringes. And I think some of that is higher based on the fact that needles and syringes can be used for other things like medical needs, such as diabetes and injection of insulin. So there is still room to grow for other states, and in 11 of those states where needles and syringes are illegal, we again see that Good Samaritan law that can be analyzed on a case-by-case basis. Some organizations have been working to increase the services, harm reduction services that are available, particularly with the COVID-19 pandemic driving. So this year, the National Council for Mental Wellbeing provided grants for 16 organizations. In the goal of this project, it's to better understand the impacts of the pandemic on harm reduction organization and on people who use drugs, and then also to support harm reduction organizations during the pandemic through funding and technical assistance opportunities. So you will see a lot of different types of harm reduction work going on with the 16 grantees. So some are general harm reduction coalitions, some are specific for certain populations like the Sex Workers and Allies Network, and being able to try and bring this on a bigger scale within the healthcare community. Another area of further growth we are seeing is obviously in the digital age, we are looking at digital therapeutics. So currently Reset and Reset-O are the only FDA approved programs or apps that are available to use. So if you are unfamiliar, Reset and Reset-O being specifically for opioid use, is a 12-week FDA-approved phone application. It provides structure and some CBT interventions for those who are also accessing MAT at the same time and working with a physician where the physician can prescribe this phone app so that we can help see it be covered by insurance companies, and being able to also look at the principles of contingency management. And the ultimate goal with all of this is to increase treatment longevity. And the goal is, and we have started to see some early evidence for folks being able to maintain that being in treatment for those 12 weeks with higher retention rates because they have also something to take home with them to continue to engage with and learn these skills, even if they're not in a traditional treatment program where they might be learning those CBT and behavioral interventions. There are other apps that exist as well without prescription that may offer a time to track alcohol consumption or be able to look at trends of use patterns and set personal goals. And I have seen some of those being used even for folks who are not seeking substance use treatment, but are finding themselves where they're more in the starting to need to access treatment or recognizing that they would like to make some changes around their drinking or substance use. And then they're being able to access these apps, start to realize that perhaps they do need more support or more treatment or ability to be able to do that. So we are starting, while we don't have a wide evidence base, which is why this is more in our future directions area, we do know that there is promising engagement with some of these phone apps because they can help bring more accessibility, since we know a lot of folks have smartphones and are able to use that on their own and reduce some of that feeling of shame and stigma if that is the barrier for them to come and work with a provider or a healthcare professional. I will pass it back over to Matt for our issues raised by harm reduction.
Okay, thanks, Lauren.
Mhm.
So we talked about, some of the different issues that can be raised by harm reduction earlier, including what critics might say about some of these strategies. I thought to mix it up a little bit, we might look at a popular media story about harm reduction. And the story we're highlighting here is from Canada, and it's on a harm reduction program that includes legally prescribing drugs for people with addiction to use for the purposes of getting high. And the article, addresses some of the ethics and ethics questions that accompany that practice. And so the article mentions that, medications being prescribed for this purpose include opioids and stimulants. However, it doesn't give detail about exactly which opioids or which stimulants are being prescribed. And the harm reduction idea here, the approach is something called safer supply. And so the thought is that if you're able to provide a safer supply of drug, that people, when they, inject substances that have been laced with things like fentanyl and xylazine, which is becoming increasingly popular, that we can make their supply safer. At one point in the story, because, providers are essentially prescribing drugs for the purpose of getting high, there's a comparison made that providers are essentially drug dealers. That's what one of the critics mentioned here. So, the program is so new that we haven't seen any peer-reviewed data on it to know whether it's working. Critics will point out sort of what I was mentioning earlier, that are we actually encouraging, drug use here, even though there might be a greater safety profile. There's also, critics would mention that there's a risk for diversion here. And so that calls into question, the ethics of this practice. Supporters say, this is a step in the right direction for some people who are struggling, and they might not yet be ready for a more traditional recovery model. And this is a way to reach out to them and to get them incorporated and start using a safer supply that might end up resulting in less comorbidity as well as less mortality. All right, the other thing about it too that proponents argue is that because you have to see a provider to get these drugs, you are at least, incorporated into a recovery network of some kind. All right, so let's look at the next slide. All right, so, the slide we just came from was looking at ethics. This slide here, I think, we talked about syringe service programs. They actually help that there hasn't been, any increase in crime related to the existence of these programs in neighborhoods. And so I wanted to take a closer look at this because this is an issue that comes up quite frequently by people who criticize this harm reduction strategy. And I think, the article this is a peer-reviewed article showing that in one example that was looked at, there was actually an abrupt and persistent decrease in crime following an overdose prevention center's opening. And then, the lead author here on this other study, the second point here, Kroll and colleagues, they've reported in their work that 90% of people using an overdose prevention center would otherwise be injecting in public places. And so, I wanted to address additional research related to crime, showing that not only is there not more crime in areas where these services exist, but there's also evidence showing that there's decreased crime. All right, next slide, please. All right, and so this is the last slide on issues or controversies related to harm reduction. We looked first at ethics, second at crime, and now I thought it would be helpful to look at cost. And so critics might say there's no way we're going to have taxpayers pay to fund people essentially to use drugs. However, the work that's been done on this topic shows that taxpayers are actually poised to save money when these strategies are used. And so the studies here, so first by Irwin and colleagues, they modeled the costs of a hypothetical site in Baltimore, and they showed that a cost savings of 7.8 million could be realized just by use of this strategy. And then there's another study from New York that showed a potential cost savings of 1.6 million. So as to the issue or controversy related to costs and using public funds for people to use drugs, there's actually cost savings according to the research that's been done on this question. All right, so that's everything I wanted to say on issues or controversies. Lauren, how about if you take it away with the first case that we wanted to talk about?
Sounds great. Matt and I put together some cases based on some clinical presentations we've seen. These are cases that have factors that are very common patterns that we're seeing in our daily practice. So quite the identified and not specific to exactly particular patients we've had. So I will start us off with our first one, looking at an individual named Martin, 20-year-old individual diagnosed with opioid use disorder and cannabis use disorder. In addition, he struggles with depression, ADHD, and anxiety. This individual grew up in a large city, a metropolitan area, lived in a quite poverty-stricken and low-income area, and through some of those social factors had significant exposure to community violence and trauma throughout his life, including witnessing some traumatic events of witnessing friends and loved ones being victims of gun violence and also being near victim himself. He struggles with coping strategies and social skills, in addition to his recent battle with opioid use. And when discussing some of the social skill deficits, looking at some of those traditional things that someone might struggle with as a developmentally adolescent individual, some impulse control concerns, struggling with effective communication, and struggling with interpersonal communication. He's also, in addition, using fentanyl and has a history of 2 overdoses prior to treatment. So is a high-risk individual entering residential treatment to address his opioid use and in the contemplative stage of change about lifelong abstinence, which we commonly see with our folks who are pretty young. He's not currently receptive to discontinuation of cannabis use, as he feels it is more of a coping skill rather than a drug. So discussing some harm reduction interventions we can use for Martin. So looking from the behavioral aspect, Martin would benefit greatly from motivational interviewing to start, meeting him at a place of where he is and where he is ready for treatment. Also recognizing that some of our recommendations for treatment and for aftercare may not be perfect or one size fits all. For example, if Martin is returning to his home environment, recognizing that he may not have access to a PHP program or IOP after residential, recognizing that his friend system and support system may not have the tools and skills themselves to support him in a recovery lifestyle. Something we discussed with this individual was changing location, which can be really a big barrier for someone who comes from a low income community and doesn't have the financial resources to do so. So a lot of discussion of long-term treatment goals, what are things that he is willing to change, from a interpersonal effectiveness and more some of the behavioral interventions. We also worked with Martin to improve some of those coping skills, because what we found when he entered into spaces where folks did not have the same social background that he did or cultural experience is that they would stigmatize not just his use, because he was in a treatment facility for substance use, but more stigmatize his behaviors. And if you'll remember on that way back slide, when I talked about barriers to treatment, mental health diagnoses can be something that also put up a barrier to substance use treatment. When he interrupted others, when he broke the rules of the residential facility, right? When there were things going on that made a lot of sense for where he was in his stages of change, it also impacted those around him and caused some rejection from his peers in the recovery community. So some of those factors we need to consider, as well as how do we educate him on his treatment journey and work with some of those things, and recognize that there may be times where a punitive asking to administratively discharge from a facility because of struggling with some of those mental health symptoms would not serve this individual very well, and learning how to work with some of that motivational enhancement and being able to help him access treatment. So Matt, I'd love to hear some of your thoughts on this case as well.
Yeah, absolutely. So Lauren, I like the points that you were making about motivational interviewing, what aftercare is going to look like, coping skills, and as well as the mental health comorbidities you mentioned. I think from a medication perspective, I'm really concerned seeing fentanyl, and my mind immediately jumps to making sure that Martin knows about naloxone. And so first, maybe learning more about those overdoses that he experienced and what those experiences were like for him. And then seeing what he already knows about naloxone, whether he has it, whether, that one study that we discussed showing that it was friends who were usually the ones who helped with overdoses, seeing whether his friends have access to naloxone as well as family members, and then, if it's looking like Martin's meeting criteria for opioid use disorder, if that's confirmed, then, speaking to Martin about medications for opioid use disorder, I'd love to hear what he already knows. Often it's the case that people will come into treatment already having tried something, or they might already have ideas about what they would be interested in being prescribed. And so because all three of the FDA approved medications work slightly differently, I would want to engage Martin in a discussion about that, especially knowing that those medications can help reduce harm. I'm thinking about that data that we looked at showing that overdose mortality was lower when people were on these medications. So those are some of my thoughts. The other thing pointing out to me, ADHD, that diagnosis, I'm wondering, looking at the anxiety diagnosis as well, whether there's a component there with his cannabis use, and then whether if ADHD is untreated, whether the impulsivity that goes along with that disorder might be contributing to substance use. So those are some of my thoughts.
Yeah, I think that's great. I think, looking at the ADHD and recognizing that, like you said, there could be a self-medication component or a regulation component going on with the cannabis use. And it makes sense why he would look at it as a coping strategy.
Mhm.
And I think, some of that education, substance education of the brain disease, helping him understand why, this may be something that he does not feel he's in the, he might be in the pre-contemplative stage for discontinuation of cannabis use, and it's something to consider for his lifelong recovery.
Mhm.
Being able to meet him there too.
Absolutely.
Great. I will move us along to our next case. Take it away, Matt.
Okay. So Anna is a 30-year-old Hispanic white woman with opioid and stimulant use disorders and a long history of anxiety. Anna is a sex worker and is undomiciled. She injects drugs and sometimes shares injection equipment with her clients. She reports she lost access to PrEP 2 months ago when she was evicted from the motel where she had been living. Anna presents to the outpatient clinic reporting some interest in cutting back on her use of illicit substances. She asks, "Is there someone I can see about getting a BUP script?" All right, and so again, here we want to explore what are some of the appropriate harm reduction strategies for Anna. And thinking about, I'll just kick us off here, Lauren. Thinking about the different categories that we discussed in the slides, again, my mind immediately goes to naloxone. Does Anna know about this life-saving medication? And if she does know about it, how much does she know about it? In particular, I'd be curious to know whether Anna knows about the half-life of naloxone. I think it's really important for people to understand naloxone works really well, but it's very quick. The half-life, people can re-overdose very quickly and not take any additional substance because that half-life of naloxone is so short. And so it's not good enough just to have one dose of it. I would want to make sure Anna knows how to use it and understand you might have to reuse it while you're waiting for emergency services to show up. And then, it's great. I love that she's already thinking about a medication for opioid use disorder. So I'd want to build off of that, learn, has she tried it before? What are her thoughts? Making sure she understands that, in order to start the medication, that you should be in having some withdrawal symptoms to prevent precipitated withdrawal, and making sure that she would be willing to do that. And I would also, as the authors of that one paper showing the protective effect of medications for opioid use disorder pointed out, I would also want to make sure that, she understands coming off of that medication, there could be an increased risk for overdose mortality if she were to decide to stop it, like some of the people in the study did. So those are some of my initial thoughts. Lauren, I'd love to hear what your thoughts are on harm reduction.
Yeah, I think immediately my mind starts going to what are some of these barriers that Anna is facing, right? Like, does she have transportation that's reliable? How does she have health insurance or access to some of those resources? Because if the answer is no, it's going to be a lot harder to get into a traditional treatment facility and be able to financially sustain that. Is it easier to work with someone who can help her with the MAT aspect? And then could we look at some of those future directions of using Reset O or something else? While looking at what other treatment grants or publicly available funding is to be able to help her in that journey of learning about early recovery and being able to start that knowledge base up. And it's a lot easier to access your primary care physician or a psychiatrist or just one person versus trying to immediately go away to a residential facility, for example, because that's not always reasonable for someone right away. I think too, there's factors of being able to, you know, if we offer places like safe injection sites, you know, to reduce that overdose risk and reduce that stigma and shame, you know, around like that some people have and those biases people have about her sex work, and being able to give her a safe place where she feels like she doesn't have to explain herself and can learn to build some trust around healthcare providers, so that she could maybe in the future begin accessing some of those other resources as she gets connected to people who can help her identify those things.
Yeah, absolutely. Those are great points, especially about the biases that she faces. Also, along with the point you were making about Reset O, maybe the last point I'll just mention here real quick about, you know, PrEP, that she lost access to PrEP. And it would be really important from a harm reduction standpoint to figure out, you know, is Anna willing to get tested for HIV? If so, using the outcome of that test to help guide treatment moving forward to help reduce harm, not only for herself, but also for others.
All right. Any other thoughts from you, Matt, on our cases?
I think that's it.
Excellent.
Well, thank you so much. Now it's time to answer a few questions from our audience. If you do have any questions, please take the time to use the Q&A feature at the bottom, not the chat feature. It's on the taskbar, the Zoom taskbar at the very bottom. We'll try to get to as many questions as we can during this time remaining of the webinar. We will also combine any similar questions that we have submitted. If by chance we do not get to your question today, please send an email message afterwards to webinars@rbh.org and we will follow up with you. So our first question today which methods have you discussed do you think is the most negative stigma attached to it, and why?
I'll start us off. I would say from a standpoint of that stigma around condoning substance use, safe injection sites and locations are likely to receive some of the most criticism. There is likely a lot of community fear around, you know, what Matt discussed, and I'll let him answer as well, you know, some of those fears of rising crime rates if we're going to allow folks to gather at a place and use substances. I will also say it never ceases to surprise me when I see things that in our fields we regard as a really big win, like I mentioned, those naloxone vending machines. You know, my thought is, hey, we will reduce overdose deaths. This is a life-saving measure. And then I'm a masochist and like to read social media comments. And then you see community members starting to come up with those criticisms. And my bubble is popped and I realize we have so much stigma work to do, and to help people realize, you know, because then there's some false equivalencies made, such as like, why are we allowing this to be accessible but not free cancer treatment, right? Like these are things we can't compare apples to oranges. And there's so much stigma around some of these, in particular, free and readily accessible resources.
Yeah, Lauren, I agree. I think, you know, those overdose prevention centers, I also agree with the points you were making about stigma. I think that those overdose prevention centers are probably are facing the most stigma. You know, it makes me think about the Not in My Backyard movement, where people might object to having, you know, sort of a service like that close to or near the neighborhood where they live. I'm also thinking about actually some of the benefits that come along with it. And so, you know, in several examples, you know, there are actually fewer syringes out on the sidewalks as a result of these centers opening. And so there's value that can be added to the safety and cleanliness of neighborhoods that can be added by having these services in your neighborhood, especially if it's a place where there's already rampant use of drugs in public spaces. So I would say that that's probably facing the most stigma. And as an organization, we're working really hard on stigma and how do we address it? How do we think about it to try to improve?
Great, thank you. We have a question here. Sorry, a few more have come in. It kind of came down. Could you talk a little bit more about harm reduction in regards to alcohol use or abuse specifically? Any more ideas around harm reduction with alcohol?
Yeah.
Specifically, yeah.
Yeah, Lauren, do you want me to kick us off here?
Yeah, go ahead.
Yeah. So, there's this category of medications called medication-assisted treatment. And there's evidence showing that when you use those treatments in alcohol use disorder, that there's less use of alcohol. There's also evidence that periods of recovery last longer when you're on medications like that. So there's a harm reduction component, certainly to the medications that are FDA approved for alcohol use disorder. I'll also mention a number of medications are used off-label to treat alcohol use disorder. And then I think, the point that Lauren was mentioning earlier about motivational interviewing, that's a source of harm reduction that's helpful with alcohol use disorder.
Yeah, another thing I'm thinking about is we hit a lot on those education pieces. So, part of motivational interviewing is not only evoking that already existing internal motivation for change, but also providing objective information. For example, how much is a serving of alcohol depending on what kind of alcohol you're consuming, right? People would be very surprised. I remember in college, some early intervention programs that were happening to let college students know what is a serving, how does your blood alcohol concentration work, how do you stay safe and not put yourself at a risk where you think you're fine to drive, but you don't get behind the wheel, and things of that nature are more targeting than that harm reduction and mitigating the risk of death through other avenues if consuming alcohol as your primary substance.
Thank you. Another question here is, can you comment on harm reduction for teens experimenting with substances?
Yeah, I think that's a really great point. Sometimes I worry that maybe teens sort of get lost in the mix because oftentimes there's comorbidity, psychiatric comorbidity with teens when they're using substances. And sometimes it's the case that child and adolescent psychiatrists will say, you know what, I just don't deal in substances. And so we need a substance expert here. And then other times it's the case that the substance expert will say, you know what, I don't really work with kids. So it can be really tricky to help this population. So I really appreciate this question. I think, first of all, you want to understand what do teens already know about what they're using? Because I think there's quite a number of myths out there. One example that's popping to mind is with vaping. And so the idea might be that vaping is safer than, say, cigarette use. Well, we also know that when you use vapes, that there can be lung injury from that. And there have been examples where particles are inhaled, deposit into the lungs and cause infection. So when I talk to teens about it, I want to make sure that they're understanding the harms associated with some of the behaviors that they're doing that they might think are not that harmful. I think it's really helpful if you know that a teen is using alcohol. You know, the point that Lauren was making earlier about how do you define a drink so that we're all using the same language, so that, you know, when we're talking about treatment goals, we know we're all reading off the same sheet of music in order to reduce harm from their use.
I think too, a lot we're seeing is, you know, those co-occurring mental health diagnoses that are happening in the teen populations. I mean, that's largely representative from a lot of the folks that I at least am seeing in practice. And, you know, being able to provide understanding of what are alternatives in coping strategies, helping them recognize when to apply those coping strategies, and really getting that foundation of education. But I also think there's been more media attention to some of those cases of, you know, adolescents in some experimentation may use cannabis that has fentanyl laced in it, right? And we're seeing accidental overdoses in those regards as well. And that's really scary for parents and the teens once they start to realize that that's something that could occur. So I think a way to have a language with families and teens on fentanyl testing strips and being able to destigmatize a little bit there, and, you know, really hitting on that being a life-saving measure for teens who are experimenting with substances.
Thank you. We probably have time for one more question. There's just a comment here, and you may or may not know the answer to this, but the slide showing the map was very interesting. You know, what might be contributing to the large areas where naloxone is not available? Does anyone know maybe that additional little bit more information on that?
Yeah, you know, it might just be a function of population density in those areas. It seemed like the trend was for, you know, the coastal regions to have lots of access to naloxone, which makes sense because of, you know, the high density cities that are on the coast. And then other cities in the US, you know, when you think about where they are geographically, it looked like there were high density resources available there for naloxone. And then I think it's probably related to population density.
Sure, that makes a lot of sense. Well, thank you both so much. That's all we have time for questions today. Remember, if I did not get to your question, please feel free to send an email to webinars@rbh.org and we can follow up with you. Many thanks today to our presenters. You both did such a great job today in this webinar. And thank you for taking the time to share all such valuable insights with us. Before we conclude, I'd like to take some time to share some additional resources on this particular topic with all our participants. You can see on the screen today that there are those additional resources that are available. That's a wrap for today. I want to remind our participants that those of you that have met the requirements and the time commitment, you'll be eligible for the CE credits within the next 30 minutes. You will receive an email with a link to the personal dashboard at cego.com, where you'll be able to access today's presentation on PDF files on a slide and a handout and complete a list of references. Again, for those of you who've met the time requirements and qualify for the CE credits, you will need to complete an evaluation of today's presentation to download the CE certificate for this event. If you have any questions about this follow-up email, please contact support@ce-go.com, excuse me. So on behalf of everyone here at Rogers, we look forward to partnering with you and to help any of your patients. Please feel free to reach out to any of us here at Rogers. Thank you. I hope you all have a wonderful day, and thank you for taking the time to join us. Bye, everybody.